Good afternoon, everyone, and welcome to today's Black Health Trust. I'm Dr. Ivan Walks, and we are so happy that you could join us today. And with no further ado, I would like to turn the meeting over to our founder, Dr. Randall Maxey.
Thank you, Dr. Ivan Walks, and thank everybody for joining us for this, what I anticipate to be a very enlightening, important discussion today with one of my heroes. Dr. Edwin Chapman is in the District of Columbia. We went to Howard University together 1,000 years ago, but he's a little bit younger than me. He's a diplomat of the American Board of Internal Medicine. He's a fellow of that same group. He graduated from Howard University College of Medicine and has practiced medicine for more than 47 years. He specializes in internal medicine and addiction medicine. And over the past 22 years, he's investigated the complex mix of addiction, undertreated mental illness, and infectious diseases, AIDS, and hepatitis. He is truly an expert, has testified a number of times in front of the U.S. Congress, recently the Governor's Conference, and we're very delighted and pleased that he agreed to spend a few minutes of his valuable time with us today. Dr. Edwin Chapman, the floor is yours.
Thank you, Dr. Maxey. I'd like to share my screen, if I may.
Yes, you may.
Are you able to see the slides?
Yes, we can.
Okay. So I have quite a few slides. I'm going to go through them rather quickly. And as I talk, a lot of the things that we're going to present are things that we had to create on the fly. This opioid epidemic has been with us as a so-called epidemic for at least 7 or 8 years, but we actually got involved in this earlier than that, thinking that we in the African-American community already had an epidemic that was about 50 or 60 years old. So when I got involved in opioid treatment 23 years ago, I thought we were talking about an epidemic then, but apparently nobody else really appreciated the situation in our community. So we really approached this 22 years ago, really looking for change and recognizing for years there were barriers to treatment. Our community was treated with incarceration, not medical treatment. We realize now that the complexity of this epidemic, that we need a systems approach. And we also realize that we need a culturally relevant approach to treatment, and that there are other things that are involved, like social determinants of health, housing, employment. All of that plays into this. So when we look at the so-called epidemic now, it's often very difficult for us to tell where it started and what was the underlying cause. About 8 years ago, Case and Deaton, two economists from Princeton, identified what they called diseases of despair, really talking about problems in suburban America that they recognized people were turning to alcohol and drugs. And for the first time, there was a decrease in life expectancy. We now know that looking at other studies, For instance, this particular study showed that within 5 years of a closure of an automobile assembly plant, that there was an increase in opioid overdoses. And this, you can see many of these sites are in Middle America and the Rust Belt. This is the scene outside of my office during COVID. So we know that that there was an exacerbation of drug use and alcohol use due to stress related to COVID. And of course, as I mentioned, if you're African American and you have a drug problem, you're more likely to go to jail than get treatment. And of course, after incarceration, your chances of employment, housing, et cetera, all decrease and the cycle repeats itself. So this is a depiction of the District of Columbia. And as I said, I started treating opioid addiction back in the year 2000, but all the way up to 2014, there were really only 83 deaths per year in the District of Columbia. Of course, the District of Columbia is not the size of the typical state. Our current population is 700,000, but what we noticed in 2015, there was an increase to 114, which was significant in that it was almost a 30 to 40% increase in overdoses for some reason. And at the time, we didn't recognize the underlying cause. We now know that it was the infiltration of fentanyl into our street heroin supply. Most of our patients started with street drugs, not with drugs from or medications or prescriptions from the doctor's office. So that number jumped to 231 in 2017 with 62% fentanyl. And you can see all the way up to this past year, 2022, that we now have 96% fentanyl. Heroin has disappeared from the streets of Washington, D.C., and the numbers the overdose rate was 448, which is a 500% increase over 2014. And you can also note, if you look at the green bar and the blue bar at the top, that most of our overdoses are older. They're not young, generally young people. And that's because these were older heroin users who have been stable for many, many years, and fentanyl got into the drug supply, and all of a sudden, we started seeing this uptick in deaths. If you look at the lower right-hand corner, you will see a little uptick in the under 16 and the 16 to 20. So we now are noticing some young people who are overdosing and dying, but it's usually not from street drugs, it's from pills laced with fentanyl. Another thing that we noticed, if you look at the bar all the way to the left, you'll see that there were very few deaths in the homeless. But when you look to the right, if you add what are called the undomiciled and you add that to the unknown, which I consider to be homeless as well, we had 113 deaths, which accounts for 26% of the deaths, those 448 deaths that we talked about. So we know that there's a correlation between housing and overdoses. And of course, this fentanyl epidemic was an East Coast thing, but we now see how these blue areas are stretching across the country. So fentanyl, this fentanyl infiltration is moving from east to west. And of course, now you're seeing it out on the West Coast and every place. And so we know that through COVID, just about every city that you can name has had an increase in homelessness, Los Angeles, New York, and we see tent cities all over the place. So in 2019, because of the correlation between the opioid epidemic and also an uptick in AIDS and hepatitis C, the National Academy of Sciences brought together 10 researchers under Carlos Del Rio from Emory was the chair, and I had an opportunity to participate on that panel, really looking for opportunities to improve opioid use disorder treatment and infectious disease treatment in a co-located environment. And we found 9 areas of barriers to care. And the first was prior authorizations. Second, drug addiction treatment, particularly the so-called data, which required that one have an X waiver in order to prescribe buprenorphine, which is one of the 3 medications that we use to treat opioid addiction, along with methadone and injectable naltrexone. Lack of data integration and data sharing because of confidentiality. Those records and mental health records are hard to really share. Inadequate workforce and training. People did not want to see these patients, and we really were not prepared for the rapid increase in these overdoses all over the country. And of course, stigma, payment, and financial limitations. The fact that in many instances, insurance companies would not pay for a medical visit and a mental health visit on the same day. Limits to so-called harm reduction services like needle exchange, fentanyl strips, test strips, etc. And then there's a disconnect between the criminal justice system and treatment. One of the first things I noticed when I began treating opioid addiction was that if one was incarcerated, they would take you off the medication. If you were on methadone or buprenorphine, if you went to jail, they said, we don't use that here. So you would go cold turkey and they would detox you. There was no other medication. They would never take you off of blood pressure medication or diabetes medication. These medications were the only ones that they would take you off of. So in 2019, July 1st, I had the opportunity to meet with Congressman Elijah Cummings in Baltimore in his office, along with Dr. Victor Scott, who's a past vice president of health at Howard University, and Dr. Beverly Anderson, who's very active in the auxiliary of the National Medical Association, and a close friend of ours, retired Major Emmett Rogers, because we saw the need to create a structure that really addressed the problems in our community. And Congressman Cummings was very familiar with methadone clinics in Baltimore and very interested in what we were talking about in building a workforce, particularly through HBCUs. And I'll never forget the statement that he made, that he said, I love research, but not research that sits on a shelf. So we were able to convince Congressman Cummings to, about 6 weeks later, to come to a meeting that we were going to have at a church in Baltimore. And these are some pictures from that church, realizing that our faith community needed to be involved to reverse some of these problems that we had with stigma, education, or miseducation. And he came, and we really didn't realize how sick he was at that time. But he gave a 20-minute speech, and you can see the audience there. We mixed his speech with music and also didactic teaching. If you look in the upper left-hand corner, We had a professor from Morgan State, and I gave a talk as well. And in my talk, it happened to be this event happened about 3 weeks after the infamous comment by President Trump talking about Baltimore having rats. And I mentioned the fact that I've toured the White House, and I mentioned that we had rats in the White House as well. So we replicated that meeting or that process at First Baptist Church in Washington, D.C. And actually the city put out $1 million in grants that went to about 20 churches in D.C. To really educate our community. And if you see in several pictures, Dr. William Lawson, who's also very active. So the group that I'm talking about, the Leadership Council for Healthy Communities, was actually put together 15 years ago informally, really addressing the AIDS epidemic, and then formally about 11 years ago. And Dr. Walks is a part of that group. So we have pastors, lay people, professionals, but we understood even then the role of mental health in all of our survival. So my question has always been, what have we learned after COVID? Well, we know that telehealth is now almost is a necessity. We know the relationship of housing to healthcare, and we know that everybody needs health insurance. And we know that those who need medication, regardless of their ability to pay, should be allowed to get this medication. And we also know that we need more points of treatment. In addition to methadone clinics, we also need office-based treatment. And I mentioned the vital role of the faith community. And finally, we need a integrated, upgraded payment system, because a lot of providers will not treat because of that. So about 5 or 6 months ago, I did an interview for PBS because we noted for the first time that the overdose rate in the African-American community had now exceeded the white community. Remember, from 2015 to about 2020, the only thing we heard was that this was a rural and suburban problem. But we realize, of course, in our community that this problem always existed. So this is a statement from Dr. Gabor Mate, who's written a number of books on stress and the relationship between mental stress, oppression, racism, and disease processes. And he mentioned on the left-hand side that the average medical student is not taught how to treat trauma. And so one of the things that he mentioned was, if you look at the model of the Sioux Lakotas, that they made a statement. Your body is not separate from your mind is not separate from the rest of our minds. We co-create each other. So your illness represents some dysfunction, some imbalance in our whole community. So your healing is our healing. How can we support you? And that's really the philosophy that the Leadership Council for Healthy Communities recognized years ago, that we need a community-centered approach to treatment. And the reason why we see such health disparities in our community is because we look at health as being an individual enterprise as opposed to a community enterprise. And so we want to really rethink that using a systems approach, bringing together not only the faith community, but other community support systems, the medical community, the legal community, government, etc. So this is what we call systems thinking. In this particular slide, we can see now that there are many things that really contribute to the fatal outcomes from opioids, and part of that is the way we currently treat substance abuse. It's separate from everything else. It's siloed. Mental health is siloed. Primary care is siloed. So we need to integrate all of those services. We also know that most of the overdoses are not witnessed. And then we also realize that 25%, and I would say really almost 75% to 90% of my patients have a diagnosable mental health problem. And most of the time it's anxiety and depression. So 50% of those patients suffer from anxiety and depression that's untreated. The overdoses often occur with a bystander present, but those bystanders heretofore rarely had Narcan to treat them. So on the left-hand side, on the right-hand side, you can see now that the District of Columbia now exceeds West Virginia in per capita overdoses. So as I said, most of our treatment was incarceration. And when you're incarcerated, you weren't given medicine. You come out of jail, and within 2 weeks, you have the highest overdose rate. This is Dr. Josiah Rich in Rhode Island. He was one of the 10 members of that National Academy of Science committee, and he instituted a program in the Rhode Island jails using medication-assisted treatment. So they started patients rather than taking patients off of treatment, and noted a 60% decrease in overdose deaths. We had the same problem with the emergency room. People would go to the emergency room and repeatedly, they were not started on medication, discharged, and overdosed. And Yale, back in 2013, did a demonstration project starting buprenorphine in the emergency room. So when we put this together with this systems approach, we can see that now all 6 hospitals in the District of Columbia have a program to start medication-assisted treatment if an overdose comes in. The jail in the District of Columbia now uses all 3 forms of medication-assisted treatment: buprenorphine, methadone, and injectable naltrexone. This is actually a public policy that was written by Georgetown Law School to address how emergency rooms should actually treat persons. So we're now getting written documents, guidelines from lawyers. Again, this is the Leadership Council for Healthy Communities, and this meeting actually occurred pre-COVID. And you'll see Dr. Walks there, Dr. Patricia Newman before she passed away. We had Ambassador Susan Coleman, who was actually the religious ambassador to the under the Obama administration. Our executive director, Sullivan Robinson, Reverend Tucker. So we actually had meetings, ongoing meetings, to discuss mental health, substance abuse, and primary care in our communities. So just recently, about 2 months ago, we put all of this together and applied for a SAMHSA grant. It's called Community Partnerships to Advance Science for Society, or COMPASS. And it's really structured such that the money goes to the community, and then the community picks the partners. So we applied for this grant under the Leadership Council for Healthy Communities and brought in partners from Howard University Community Medicine, Howard University College of Pharmacy, Georgetown University Law School, and MedStar Family Choice, which is one of the 3 Medicaid companies in our community. We also recently got a grant from the District of Columbia Department of Behavioral Health to start a pilot demonstration project for people who are returning citizens who are on substance abuse treatment with buprenorphine or injectable naltrexone. So the Biden administration has made really the criminal justice system and treatment of opioid addiction a priority for 2023. And we combine those resources, those public policy papers from Georgetown into an integrated project from the Leadership Council for Healthy Communities. And this is a picture of our first meeting in the DC jail to really connect with people who are coming out, to keep them on their medicine, to guide them in terms of getting follow-up health appointments to primary care, substance abuse, mental health, housing, etc. We're all familiar with the new Jim Crow and the prison industrial complex. So really what I'm saying is we are developing a systematic approach to reverse engineer all of that. That means that we also have to intercept or intervene before someone goes to jail if they have a substance abuse problem. And that's called law enforcement assisted diversion, identifying somebody who needs help and to get them into treatment before they get into criminal activity. This was first recognized by Lisa Gargard, who was a lawyer, and the University of Washington found a 39% reduction in felony charges using this approach. So these are scenes outside of my office and actually in my office at 17th and Benning Road in Northeast Washington. I've witnessed overdoses outside of the office, and we had 3 patients to actually, on separate occasions, for the first time, to overdose in the office on Narcan. And we were able to successfully resuscitate all 3 of them because we have Narcan in the office. But the problem is that there's no forced transport for these patients. The city has now, and the police department has taken an approach that we're not going to take you to the hospital if you don't want to go to the hospital, which means that that really allows someone to overdose again on the street. So we think that that public policy needs to be reversed because we don't have that third option or a respite center because we know a lot of these people who overdose on the street are homeless or have economic problems or mental health problems. So they need, if they're not going to be admitted to the hospital, they at least need to be taken to a place where they can recover for 4 or 5 days, and we can get some history from them. Now, a major problem across the country, as we mentioned and as we all know, is the increase in homelessness in tent cities post-COVID. The District of Columbia had this problem even before because we have one of the fastest, if not the fastest, gentrifying city in the country. So that has led to tent cities all over the city. We also had a recent report from HUD showing that 1/4 of our public housing is uninhabitable, and we have many inhumane public health policies related to the homeless. And these are just some of the pictures from the community. And we know that housing actually reduces medical costs. So we can't separate housing from medical treatment. And this really shows in McPherson Square about a month or two ago, the forced removal of tent cities. There was no systematic placement of these individuals, which means that the only thing that happened was they just moved to other parts of the city and repeated the cycle. This particular tent city, of course, was on the west side of the city, downtown, where the tourists are. And now we see these same individuals on the east side of the city, where my office is. And now my parking lot is an open air drug market. And I put an arrow there. We also have witnessed murders. We also have the highest AIDS and hepatitis C rate on that side of the city. So I call this a tale of two cities. This is government malfeasance. And these are pictures actually from the parking lot in my medical building. So we don't get the same treatment as the people on the west side of the city, even though it's a medical building with a dentist's office, a pharmacy, etc. But because of who we are, we're treated differently. So one of the proposals, and I showed you Major Rogers earlier, was how can we help people get the housing that they need in an orderly manner? So why not use the National Guard? So we now have a new governor in Maryland, and his motto is "Leave no one behind." So the fact that our governor is a Army veteran, and my associate is an Army veteran, and the new Secretary of Health under the governor is an Army veteran. And this is a statement that she made. Years ago, I provided HIV care, and when I was trying to get people on antivirals, antiretrovirals, I had plenty of patients that said, "Doc, I need a place to put my head tonight. You find me a bed, and then we can talk about your medicines." So again, we see the relationship between stress and housing, and whether or not our patients will take their medicine. Recently, SAMHSA or NIH put out $60 million to 24 medical schools, including Charles Drew and Meharry, and they want those medical schools to really address the homeless population, substance abuse, and mental health problems. So we're right on track in developing this model through our medical schools. Howard University and Georgetown University recently were awarded a $3 million grant from the Mellon Foundation to apply humanities in reducing health disparities. So we're really understanding that you can't separate our humanities training, our social work training from healthcare. And this, again, we had to create these structures. So this is the Urban Health Initiative. Again, Dr. Lawson, this is when I actually was invited back to Howard University when Dr. Lawson was chair back in 2013. And I told him, I said, "Dr. Lawson, I'm not a psychiatrist." He said, "It doesn't matter. We need to integrate these services." And that program has now evolved to today and become one of the premier programs in terms of using telehealth, peer support specialists, social workers, psychiatrists, lay people in developing an integrated treatment model. So this is the proposal. Why not use the mobile Army surgical hospital approach to care in really removing systematically humanely moving people out of these tent cities. So the theory is, if we come in and give them what they need and what they want, food service, clothing, sanitary showers, toilets, safe perimeter, access to emergency services, you build trust. So you get command and control of those areas. Then the next thing is to go in and systematically triage, uh, uh, get a social profile, get a mental health profile, get a medical profile right on the site. And when we do that, we can then systematically understand where to place them once they're moved. But rather than going with the police and heavy equipment, we would do it in a humane manner. So these are the ASAM levels of care for substance abuse mental health treatment. We know that level 4, of course, is the most severe. Some of the patients will require hospitalization. Many will require residential treatments, particularly those who are homeless, intensive outpatient care, and then some may be placed in permanent housing. So instead of having the old way of going in and just forcibly removing people, we would use our academic approach. This is a Howard University Urban Health Initiative today. They have peer support services, social workers. I give talks to Georgetown Law School, who write many of the policies for the White House Office of National Drug Control Policy. This is Shelley Weissman, the Deputy Director under Regina LaBelle, who was a former Chief of Staff of the White House Office of National Drug Control Policy for 8 years under Obama, and most recently, the acting drug czar in 2021 under Biden. These are their students, and these students come from all different backgrounds. Some are people with lived experience who actually recovered from drug treatment. Others are physician students or want to go to medical school or nursing school, et cetera. Are all participants in this, and of course, the Leadership Council for Healthy Communities. So I'm going to move to some of the regulatory problems that we have. We've known for a long time, I mentioned buprenorphine, but we've known for a long time that there was discrimination in the dispensing of this medication. It's classified as a class 3 narcotic, office-based, and so the manufacturers wanted to maintain that availability, but they did not want it to really be distributed in urban populations because they thought that it would be diverted and then become a Schedule II drug like methadone. And so this long study done by Dr. Helena Hansen when she was in New York that showed that the distribution of buprenorphine generally went to higher income zip codes and methadone lower income zip codes. And she's written a number of works. This is a paper that we presented at the National Academy of Sciences, showed that only 2.7% of African Americans have access to buprenorphine. The other problem was that buprenorphine was generally capped by many insurance companies in many states at 24 milligrams. And most of those studies were done before fentanyl. This is Dr. Edmund Salsitz, who really showed that 200 milligrams and 24 milligrams of buprenorphine is a totally different world with fentanyl, which is 50 to 100 times more powerful than morphine. We wrote 2 papers at Howard University. One published 2 papers. through the School of Pharmacy in 2017, a case study in 2019, a series showing that higher doses actually work better in our patients. Today, we're still fighting to get these buprenorphine caps removed. And you can see this is an old slide, so I don't know whether these state caps are still where you see them here, but you can see that they were as low as 8 milligrams in some state. So imagine if you were on insulin and you needed 50 units of insulin and your insurance company would only pay for 25 units of insulin. So these are 3 states that have actually raised that cap. And the way the insurance companies do this is through prior authorizations. They will have a pharmacist who I found frequently are not even licensed in the District of Columbia block our prescriptions. On the left-hand side, this actually shows that during COVID, in spite of the increase in overdoses, there is only 2% of patients who overdosed and died had buprenorphine in their system. So we now know that diversion is not a problem. And this is in the District of Columbia. Again, we showed that there's actually been a decrease in buprenorphine and methadone being present in patients who died, and they're under 3%. So these medications are really not being diverted and causing deaths. They're being used really to relieve symptoms. This is a letter or an email to me from the Senior Legislative Counsel from the American Medical Association saying that all prior authorizations and dosing caps should be removed for these medications. The same for naltrexone. I told you about the 3 patients that overdosed in my office. Again, Dr. Salsich showed that half the patients who overdosed and died from fentanyl died within 2 to 3 minutes. And the way they discovered this was that at autopsy, they looked for norfentanyl, which is the metabolite that goes through the liver. And they found that half the patients did not have norfentanyl in their system, meaning that they died in less than 5 minutes. So you can see on this graph from Philip Coffin, the difference between a heroin overdose death and a fentanyl overdose death. You have up to 90 minutes, 30 to 90 minutes before you get cardiac arrest with heroin. You got 5 to 20 minutes at the most with fentanyl. And you can see that respiratory depression occurs within 0 to 2 minutes.
Dr. Chapman,
yes.
You know I hate to interrupt you because you are educating all of us. And at the same time, Dr. Maxey is going to beat me up if we don't leave some time for questions.
Okay.
This is your fault because you know so much and you need to give us so much. So can we have you summarize and then plan to have you come back and finish, please?
Absolutely. And I just give me 30 seconds.
You got it.
I just want to mention the nitazines and xylazine. The nitazines are another class of potent opioids that we generally don't even test for in my office. And xylazine is an animal tranquilizer. All of these are now in our drug mix. And I just wanted to show you this one slide of a patient that I did at random. I did 5 patients just to see, I used another lab just to see what we were missing. And you can see that this patient tested for fentanyl, cocaine, xylazine, and designer opiates, all in this one sample. So the 3 patients that I resuscitated in the office, I gave 6 4 milligram Narcans because they had what we call wooden chest syndrome, and all six were successfully resuscitated and are alive today. So I'm going to stop there.
Dr. Chapman, thank you so much. You and I talk a lot, and as you said earlier, we've had the opportunity to work together on many of these challenges, and I just have to shake my head because and I want you to comment on this if you can. As a physician, you know how to do the doctor thing. The part that's always challenging is the policy thing. And so I'm glad that you brought up the opportunities with the new governor of Maryland. I'm glad that you brought up some of the challenges with some of the jurisdictions and how inconsistent things are across jurisdictions. How is it that we get at the part that gets in the way, which is this whole thing about not transporting someone when they've just been revived from an overdose that probably wasn't intended. They were just trying to use what they use. So can you talk a little bit about that challenge of the health piece and the policy piece?
Can I add on to your question, Dr. Walks? I see on the news every day how all of this fentanyl is coming through the Mexican-California border, Arizona border. But according to you, Dr. Chapman, it's coming from east to west. And my thought is that whatever the United States government and Big Pharma doesn't want to happen, doesn't happen. So give us a high level look at that in terms of policy. Why is all this fentanyl on the street in the first place? Is it a premeditated occurrence at our expense?
Yeah. I think we're being systematically poisoned. I just saw a study that showed that, for instance, California, I think it's now 76% fentanyl, but we've been at 91 to 96% fentanyl in Washington, D.C. for going on 3 years now. So these drug cartels are businessmen, and they study our weaknesses. They know what our policies are, and they're always a step ahead. These newer additives that they're putting in the drugs that we're not even testing for, they realize that okay, if you're going to put Narcan every place, and then we're going to find something that works even faster. But that whole issue about where the drugs are coming from, you got to realize that if you go from a heroin agricultural base to a synthetic base, that it doesn't matter how they can mail this stuff in. It doesn't have to go through Mexico. It just so happens that the cartels in Mexico were good at creating these lacing these pills to look like Percocet, to look like anti-anxiety medications, etc. And you can order those. Kids are ordering them over the internet. So you can mail this stuff in. It doesn't have to come across the border anymore, and they're much smaller packages. You can put enough fentanyl in about 5 suitcases on top of a desk to kill everybody in this country. To give you another example, Arizona, they found a house with 445 pounds of fentanyl in a house in Arizona. Again, whether it came from Mexico or whether it came directly to Arizona is another question. The point is, the point of entry or the port of entry can be any place. And these are very small packages. There's no way that you can intercept them all.
No, thank you so much. Dr. Hines, I know you're chomping at the bit. Are there anything we need to address in the chat as well as you ask your questions?
So there's a question in chat that asks about, is there any inclusion for bipolar disorder? Are we just talking about opioid disorder? And where I think that kind of question is lying is, and I'm going to take some liberty here, is the correlation, and you touched on it several times, the correlation between treatment for the mental health disorder and treatment for the opiate use disorder. And I will also add to that question, what about when we're talking about office-based treatment, especially in the primary care settings where you might be able to prescribe the buprenorphine, but you may not be best suited to actually really get at the heart of the trauma or whatever it is, the mental health issues that are also contributing to the problem. Do those things need to go together? Can they be separate? Like, is that a reason to hold until all the pieces in place? How would you talk? Can you talk about that a little bit?
And that's where the telehealth comes in. And that's why we created this telehealth model with Howard University. It's been about 7 years ago, actually, to address that. I'm not a psychiatrist. And so having Dr. Lawson, my vision was, how can I get a psychiatrist to see my patient? The public policy problem is that many insurance companies will not pay for 2 visits on the same day. So here, I got the patient in my office. He's come in to get his prescription for his buprenorphine, but he also has a mental health issue that needs to be addressed. How can I get that mental health visit taken care of while that patient is there? If you give them a paper referral, the chance falls off about 80%, and we don't have to repeat those studies. So the point is, if I could get that televisit on the spot, that we could take care of that. One of the solutions that I think is that we should have bundled payments and actually remove the insurance companies out of this mix. We could use a Ryan White type model where that bundled payment, let's say it's $1,000 a month, then I could pay the psychiatrist directly. Now you say $1,000 a month to treat this patient, that's $12,000 a year. Do you know how much it costs not to treat that patient? And that's in the latter slides. The average cost of one of these patients untreated is about $68,000. When you add criminal activity, physical health problems, AIDS, hepatitis C, you're talking a whole lot of money not to treat. So treatment saves, the return on investment is tremendous.
There was another figure you gave. You said that they gave about $60 million to the medical schools to treat drug addiction. But I know we've given over $100 billion to Ukraine to fight that war. So it's only still only a pittance coming to treatment of our patients.
Absolutely. The numbers are the numbers are the difference in the numbers. You just really can't compare. Pew did a study that showed the total cost is about $142 billion. So if you have 2.1 million patients with suffering from opioid use disorder, again, that comes to $68,000 a year. Even if we provided medication, mental health, primary care, substance abuse treatment, if it came to $20,000 a year, you save $48,000 per patient. It's tremendous savings.
Let me ask one more question before Dr. Walks gets in the mix here. I'm very concerned. I saw a lady testifying in front of Congress, and she was saying that she was angry because her son died of a fentanyl overdose. And she was blaming the congressmen and the senators for not getting at the cartel people who brought this across the Mexican border. But is there something missing in the way that we bring up and teach our kids and youngsters? Why should you be taking a stupid pill that you got from a friend anyway? You don't know whether it's laced with fentanyl or whatever. Why are we such victims? Why do we use so much illegal stuff?
I think that answer is in Gabor Mate's newest book, The Myths of Normal. And in that book, he talks about our culture as being our environment is toxic. Look at what's on the news every day that we're seeing with Donald Trump and this overt racism, and then these followers of Trump who are talking about removing critical race theory, telling us that we shouldn't study our history. We shouldn't talk about our history. We're not really trying to punish people, but that is our history. And if we don't deal with our history, that is stressful in and of itself, because then we can't teach our kids why they shouldn't do what you just said.
So you saying we shouldn't be woke?
We shouldn't be woke. And that's what they're trying to tell us. That's how crazy it is. You know, I always think about Lee Scolati and Francis Welsing.
Oh my goodness.
And Nathan Hare. I took Nathan Hare's social studies class second semester my freshman year. And I never forget, if you remember Dr. Hook Hall. So Hook was still in about his 7th year of undergrad, but I'm a little Indiana, small town Indiana guy, and all I did was sit in that class and my head was just swiveling as they went back and forth talking about, but now I understand.
There's another guy named Boo. and Dr. Neely Fuller.
Right, exactly. All linked together. That's
so Dr. Walk, is that resident psychiatrist? You need to jump in.
So Dr. Maxey, I know that you and Dr. Chapman have so much that you can just talk about relative to this topic. And Dr. Chapman and I do talk a lot relative to this topic. What I'd like to propose, because we are at the end of our hour, I'd like to propose that we have Dr. Chapman and Dr. Lawson come on and talk about that partnership that Dr. Chapman mentioned, and talk about the importance of all of the different aspects of the human that we are trying to work with. This human that has problems related to opioid addiction or some other addiction, alcohol. A lot of times you get alcohol and opioids and everything else in there. People have financial challenges. There are, what Dr. Chapman talked about what Dr. Chapman illustrated in his talk was the disparity of resources that are available based on where someone lives or what have you. This is, and what I'd also like us to do going forward is to talk about how we can intervene with the individuals and with the local governments to make sure that we put things in place. Dr. Chapman, I know, has several workable, reasonable, duplicable interventions that need to be publicized, that folks need to get behind so that we can make things work. It's an opportunity for us across the country to get that information and to begin to work locally wherever we are to put things in place. So I see Dr. Lawson on there. Dr. Chapman, does that sound like a reasonable next step for us to get you guys back and do this?
Absolutely. That's really what the Leadership Council for Healthy Communities is all about. That's what our Compass proposal is all about, is to create that template that can be replicated across the country and all of our communities. And the fact that, Dr. Maxey has been on the forefront he talked about me. I'm following him. He's the one that started the Mississippi Hump Project, you know, and here I am a student. And I said, wow, I said, these upper class medical students are going to go to Mississippi and help out. So that's been in the back of my mind for the last 50 years. You know, I can't get that out of my mind, that this is what we do. It's creating services for people. And when we create those services, we innovate. We have to innovate.
Dr. Walsh, I accept your proposal with one proviso. You have to be in that mix too for that program.
Dr. Maxey, I'm always happy to work with Dr. Lawson and with Dr. Chapman, because it really does need to be all of us working together. My only challenge with Dr. Chapman is that he just throws out like he's been doing something 50 years while he's looking like he's 40 and has the energy of somebody who's 30. So it's hard to hang with Dr. Chapman. I've never met anyone with, well, that's not true, because I know Dr. Maxey. Were they handing out something in the student union when you guys were at Howard?
It's called Moof Juice. Well, I know we're at the end of our time.
Yes, sir, Dr. Maxey. Happy to
I know we're at the end of our time. Let's ask Dr. Chapman to give some final comments, and let's have our moderator to give our final comments as we get off of our phone. I know this is Palm Sunday, right?
Yes.
Dr. Chapman, thank you so much for this hugely educational talk, and we definitely welcome you back for at least once, if not two more times. You have so much information to give us. I'm so thrilled about what you've talked about. Would you give us a summary and maybe even a teaser of what you're going to teach us next time you come, and we'll work out a date?
So we're really looking to develop what I call an incentivized model that incorporates patients, providers, and pharmacists. Each of those areas, we found that there's been pushback. Only 1 out of 10 patients who need treatment actually get it before they die, which tells us that because of stigma, our patients don't come into the office. Our providers don't treat. So we've created a model that will actually incentivize all three, that I think will actually increase our ability to treat. And we can talk about that next time.
Well, thank you so much. We really appreciate you coming. And Dr. Hines, do you have any final comments? And is there anything in the chat you need to address or want to address?
There are multiple comments in the chat, which I think are going to have to wait till next time. But I did, again, just thank you, Dr. Chapman, for all of the information that you gave. I learned a lot individually too. We spoke previously about having Narcan or things like that around, because people they don't know what they're using, and you're especially that last graph right before we took the break illustrated you've got to be ready to act, right? Because the timing for that is short. So it was just very informative, and I'm looking forward to next time as well.
Dr. Ivan.
So my final comment, I wanted to emphasize something. Dr. Chapman talked about the cultural component of all of the things that he mentioned today. With the FDA's recent allowing of Narcan to be over the counter and what have you, I want to point out that it's not a magic bullet. Dr. Chapman did mention that you may not have enough Narcan to reverse the overdose, and then without people being transported someplace safe, a lot of times what you do is either put somebody into opioid withdrawal, or you mess up their high, and now without any further support, they're going to go right back out again and possibly overdose. So this is not a simple, Narcan was approved and it's over. This is a significant step forward, and at the same time, this is a very complicated issue that involves more than just let's give somebody a drug or a pill or a nasal spray and everything is good. It is not that. So I just want to encourage folks to keep up with what Dr. Chapman presented today and to look forward to Dr. Chapman and Dr. Lawson joining us again to talk about how all of this goes together, both as a challenge and as an opportunity for us to move forward.
Thank you so much, Dr. Walton. And I hate to ask you again, Dr. Chapman, but is that Narcan over the counter? Is it covered by insurance? How do people get it and they don't have resources? Is that another barrier?
That is my fear, that if it becomes a commercial product, right now my patients can get it for free. But if it becomes even, I can't put a dollar amount. If it was $1, I have many patients who would not spend that $1 to buy Narcan. It has, as far as I'm concerned, it has to be free. We need to treat this really like the Defense Production Act, where the federal government takes the responsibility to make sure that it's out there. But I think it's going to be buried.
What company makes it?
I'm not sure. There are actually several companies. There's a Japanese company that has an 8 milligram dose, and that was approved by the FDA 2 years ago. And that's one of my concerns, is that the Narcan comes in 4 milligram dual packs, which means that you only have 8 milligrams. I gave my patients 16 milligrams in less than 4 minutes. That's not the protocol that they use. And had I not given them that much, they probably wouldn't be here today. They didn't budge with 16 milligrams. So I'm pushing for 8 milligram dual packs at least, because we're going to lose. I think we're going to lose a lot of patients who simply because we don't have enough. They didn't get enough Narcan. This xylazine and the nitazines mixed in with fentanyl, and that's why I showed you that slide. My lab does not test for those. I used another lab just to see what I was missing. And we did 5 patients, and that one patient came back with both of those drugs. Nitazine is xylazine is called Trank. It's reported in Philadelphia. They reported it in some suburban counties in Maryland, but now I know for sure it's in DC.
Well, thank you again so much. We got a lot more to talk about. I'm afraid patients can relapse on that Narcan if they've had fentanyl. So we got a lot to talk about. Our thoughts and prayers are with our missing co-moderator today. She's recuperating. We wish her the best. Everybody enjoy their Palm Sunday. See you next week. Thank you very much.
Thanks, everyone.
Thank you.
Thank you, Simon.